course of next 20 minutes is to give a brief overview of what influenza is like, talk about the scene of influenza in the country and in Kashmir, give a snapshot of that, and talk briefly about influenza vaccines and as to what are the challenges with us for universal influenza vaccination. Talk of influenza, it is one of the commonest infective viral diseases that affects the world's population. 5 to 10% of world's population is affected every year. 3 to 5 million severe infections and about 500,000 deaths. In USA alone, around 36,000 deaths annually, with a whopping cost to the exchequer. We all know it's a member of the Orthomyxoviridae family of viruses. There are 3 major types, A, B, and C. A and B cause human disease. C causes a mild respiratory illness. And A and B have further subtypes. B is divided into 2 Victoria and Yamagata lineages, whereas A has 2 cell surface glycoproteins. One is the hemagglutinin, second is the neuraminidase. There are 16 types of HA and 9 types of NA proteins. And they have a way of combining one with the other. And that gives you the string, like H1 combines with N1, gives you H1N1, and the like. Taxonomically, you define influenza virus as, you say A, that's the virus type, then give the location where from it has been reported, that's the geographic location, like Fujian in this particular case, and give strain number, the year of isolation, and the virus subtype. Influenza in most of the patients is asymptomatic. In nearly up to 50% of patients can be symptomatic. But usual common symptoms include abrupt onset of fever, upper respiratory tract infections, like sore throat, unproductive cough, runny or stuffy nose, headache and myalgias, bony and body aches. Uncommon symptoms include photophobia, abdominal pain, and diarrhea. Children might experience high fevers that can lead to febrile seizures. And fever may be absent in the elderly. Presenting sign might be only anorexia, lassitude, or confusion. Patient sheds the virus from 1 day prior to onset of his fever till about 5 to 7 days. And this virus shedding is prolonged in people who are immunocompromised and in children, where it may last for weeks to months. The picture that you see is a virion in the respiratory mucosa. There can be complications, which can include croup in children, pneumonia, ARDS, secondary bacterial infection by strep pneumoniae and staph usually. Myositis can occur in children. Cardiac complications are known. You can have serious complications in the form of peripheral nervous system involvement or encephalopathy. Rarely, Ray's syndrome has also been reported. Sometimes there can be unusual complications, like in this particular case, we had a skin rash and subconscious level hemorrhage in an adult with a pandemic H1N1 influenza. And so we know that winter is coming, and one of the commonest maladies that plagues our emergency systems is acute exacerbation of COPD. Does influenza contribute to the causation of acute exacerbation of COPD? The answer is yes. We did a study of around 500 people, and we found that 40 of them had an exacerbation that could be attributed to influenza. So yes, influenza is causative of an acute exacerbation of COPD in up to 8% of the patients. And patients with influenza, AE-COPD, are more likely to die during hospitalization. Diagnosis, a variety of diagnostic methods are available. Rapid tests are available, RT-PCR is available, and we can use virus isolation and molecular testing to isolate. A word about rapid diagnostic tests, that this is the only study that's been done from the country. We compared the rapid influenza diagnostic test versus the RT-PCR, which has become the gold standard of diagnosis. And you can see that the sensitivity of RIDT was only 23%. It was not more than 23%. It has a high specificity, irrespective of the age of the person and type of virus. The RIDT has a very low sensitivity, so not a very great test to do. And if you have a negative RIDT, it may not rule out influenza. So coming to influenza in India, there has been limited data from 2004 and mostly concentrated around certain outbreaks from 50 to 2000. till 2004, when there was a cooperative agreement which was signed between the CDC of the USA and the ICMR for strain surveillance in the country. So they would take 5 to 10 samples from 8 different centers in the country, which are shown here. And these samples would be tested for influenza, and then these strains would be deposited for confirmation and depositing in the repository of the CDC. And on the basis of this surveillance, this was the first major paper on influenza that came out in 2004, 2008. That was actually first authored by Mandeep Chanda and Shobha from the All India Institute of Medical Sciences. And they found that 4% of their patients had, of the around 13,000 samples that they had tested, had evidence of influenza. And this, as you can see, these bars, they are, that you can see these small bars, they are the number of samples tested, and the different colors depict various kinds of subtypes of the virus that they have seen. So influenza across the country, that is, these are 4 cities, that's Kolkata, Chennai, Pune, and New Delhi. In all the 4 states, the concentration of influenza activity was at the time of rainfall, and generally in the summer months. And this is the largest ever paper that's come, and it has data from Srinagar as well. They tested around 23,000 samples, and around 14% positivity is there. A word about the 2014-15 outbreak across the country. More than 33,000 confirmed cases of pandemic influenza mostly were reported, and there were nearly 3,000 deaths. And this was the paper that created a furor across the country. There were 2 MIT scientists from the Massachusetts Institute of Technology who reported that the virus repositories which were there in the GenBank had evidence of a mutation which conferred a higher virulence to the virus. And this created a big problem because nobody had reported it from the country. However, once the circulating viruses were tested by the National Institute of Virology, they refuted this claim. So this was not there. A snapshot of influenza in Kashmir. This is a very favorite photograph of mine because it actually depicts the time that influenza came to Kashmir. In fact, it was confirmed. There was a respiratory infection and control in healthcare facilities workshop in Delhi. And I happened to attend it, and there I came to know about this network. I talked to the chief of India Influenza Center, that was Dr. Renulal, who's here. And I told her that we also have up in the north of the country a lot of influenza-like illnesses. And she said, you get us data. If you can get us data, maybe we can help get you into the loop. So on the basis of that, we had this data generated, and for the first time we demonstrated that pandemic and seasonal influenza viruses are a cause of acute respiratory illness in Kashmir. And this was, we just collected samples from here. I sent it on my own money to Delhi, and it was tested subsequently in Delhi and then in National Institute of Virology. And as a result of this data, we were allowed entry into this network of laboratories across the country. And we were given equipment. It was 2010. Kashmir was in turmoil. I told them that I can't get equipment here, so please buy the equipment for me. So they bought the equipment there and shipped it here. My institute gave me the lab space. We set up a lab, and an influenza lab was for the first time set up. A stringent quality control is enforced with EQA participation, and I'm proud to say that our concordance with the CDC and the NIV was always 100%. So we went on looking at influenza strain surveillance, and in between we also captured certain outbreaks. And in this particular case, this was one of the outbreaks of influenza B, which is the only ever reported from a nomadic community in Sangarvini in Jammu and Kashmir. We also documented in 2012-13 that there was a resurgence of pandemic flu. This is 2009, 10, 11, then 12, 13. And here we could say after about a year, we showed that there was a resurgence of pandemic influenza. And this is Srinagar's participation in the largest study across the country. We can show that Srinagar has an influenza activity which is concentrated around the winter, whereas rest of the country It is mostly in the summer with a small blip during winter. And this is Srinagar's contribution to the 40,000 samples that we talked about. We have the highest prevalence of 18% across the country. Of around 4,000 samples we have tested, 18% have been positive. This is the 2015 outbreak, and as you can see that it exploded around February, and then we had around 2,000 samples that we tested, and 30% of them were positive. There were 16 deaths, and 4 of them were pregnant females. A number of medical doctors have wanted to know whether our virus that was circulating in 2015 was different from the other viruses. Was it somehow more virulent? This is the sequencing. I don't want to go into the details of this. This is called a neighbor joining sequence, whereby you relate one strain with another strain, and this is the sequencing that we have done of the Srinagar isolates. They actually had clustering along with the A. California virus, which is the strain present in the vaccine. Next time I come to influenza vaccination. It is the most important factor, which is the most important measure of preventing yourself from getting influenza and influenza-related complications. It reduces the likelihood of developing influenza illness by around 60%, reduces the severity of disease, and reduces the likelihood of transmitting it to others. It reduces the risk of pneumonia by 60%, influenza-related hospitalization by as much as 50 to 77%, and influenza-related deaths by 75 to 80%. Influenza vaccines have evolved over the years. From a single virus in 1933, when influenza type A virus was isolated, the first inactivated monovalent vaccine came into being in 1938. Then influenza B virus was isolated in 1940. In 1942, we had a bivalent vaccine which covered influenza A as well as influenza B. And in 1978, we had a first trivalent vaccine with 2 influenza A strains and 1 influenza B. Parallel to this, there was an advancement in technology. Earlier, there used to be vaccines that were made on the basis in egg embryos or chicken embryos, the egg-based vaccine. Subsequently, in 2007, first cell culture-based vaccine was launched, and in 2013, the first insect cell culture vaccine was approved by the FDA. I'm not sure whether you'll be able to see it. There are 3 types of influenza vaccines: egg-based, cell-based, and recombinant flu vaccines. In egg-based vaccines, viruses are grown in eggs. They are given, on the basis of the strains collected from across the world, they are given to pharmaceuticals. They inject them into eggs and allow them to replicate for a few weeks, from days to weeks, and then the virus-containing fluid is harvested, inactivated, and the antigen is purified. In case of live vaccines, they weaken the virus. In cell-based vaccines, virus is grown in eggs again, mixed with mammalian cells, and these are canine cells mostly, allowed to replicate. Then the virus-containing fluid is harvested, again inactivated, and the antigen is purified. So what is different for recombinant flu vaccines is that we don't use eggs at all. We get proteins which are isolated from the commonly circulating or the wild type of the virus. It's combined with another virus which is generally non-pathogenic, like a baculovirus, that grows in insects. It's allowed to grow in insect cells, and then the flu HA protein is harvested and purified, packaged, and released. Virus-like protein technology, the virus-like particles technology. So the genes are encoding for HA, NA, and M proteins are put into the virus, that is the center of this. Then we have a cell culture with the insect cells, and then generation of the virion-like, which is the VLP. VLPs, they mimic the influenza viruses. They have all the genetic sequences except that they're non-infectious. This is data provided to me by the sponsors. This is their VLP vaccination trial data in Indian context. They're used in a 2:1 design 300 patients and 150 placebo. And they've shown that there is an increase in the titers of more than 40, in more than 70% of vaccines in all the 3 strains, suggest to that it is seroprotective. And then there is seroconversion, which means a 4-fold raise in more than 40% of vaccines for all the 3 strains. Cell-based and recombinant-based vaccines do have an advantage over egg-based vaccines. A, they can be used in patients with egg allergy. B, it ensures a closer genetic match to the circulating strain because it takes much lesser a time for them to be framed. There's a rapid production, and from as much as 7 to 8 months for egg-based vaccines, you can get them prepared in around 3 to 3.5 months. There is no reliance on fertilized egg supply, which is a very big problem, and can be given even in patients in whom live vaccines are contraindicated, like immunocompromised individuals. However, the minus is that it is a shorter shelf life, and there is no data which shows that it is effective in ages less than 18 or more than 50 years of age. But the real revolution in influenza vaccines were these 2 papers which were published on exactly the same date on the August of 24th of this year. This is a paper in Science, and followed, and same day there was a paper in Nature Medicine. I'll explain it a bit further. As you can see that here in the diagram, the HA, which is the principal protein in the vaccine, has 2 parts, the head and the stem. Head is the variable part which undergoes drifting of the antigen and can be a problem for, that's why we have to make a vaccine every year. The stem is actually unstable if the head is removed. By dint of these 2 major studies, they found methods of stabilizing the stem, and then they developed vaccines which were protective in mice once they were infected with H5N1. This is a major revolution, and this could be the harbinger for development of a universal influenza vaccine which is effective against all strains of influenza viruses, and also we may not have the need for giving a booster dose every year because we would not need to take care of the antigenic drift or the shift. A word about the ACIP recommendations for seasonal flu vaccination. They say that the recommendation is that annual flu vaccination should be given to every individual more than 6 months of age for the current season, and especially to these people who are at high risk for influenza complications, which means people at extremes of age, less than 5 years or more than 50 years, people with underlying chronic pulmonary, cardiovascular, hepatic, or cognitive disorders, hematological, immunosuppressant patients, patients on long-term aspirin therapy, patients of, who are residents of long-term facilities, and patients who are pregnant in the current influenza season. These are the strain, constituents for the current vaccine. We have A. California H1N1, A. Switzerland H3N2, and B. Phuket. We also have a quadrivalent vaccine which has an additional B strain, but that's not unfortunately available in the country. We have to give annual pre-peak vaccination, and that time for vaccination in Kashmir is possibly now. And we take a quick look as to what do physician bodies and societies in India recommend regarding influenza vaccination. I'm a member of the first two, the API as well as the Indian Chest Society. Unfortunately, both these societies have taken the stand that there is insufficient evidence for influenza vaccination in asthma, COPD, or routine vaccination of healthy individuals in the country, so they don't recommend influenza vaccination. However, Indian Academy of Pediatrics, Geriatric Society of India, we have given their recommendations just a couple of weeks back. FOGSI, that's the Federation of Obstetricians and Gynecology of India, they give recommendation for using it in pregnant females more than 26 weeks of pregnancy from this year, April. And there was a recent recommendation for healthcare workers by the Ministry of Health and Family Welfare that again came in April, May this year. Despite these recommendations, there's a huge gap. And this is one of the only bold papers, that's the burden of lung disease papers from the country, and we from SKIMS are a part of this study. And here you can see that the uptake of influenza vaccine In patients of chronic obstructive lung disease is 0. What about diabetes? Again, we did around 1100 diabetics, and of the 1100 diabetics, only 9% had been vaccinated against influenza. And everybody, whoever was told by his physician that you must take a vaccine, did take the vaccine. What about pregnant females? Again, another study, about 1,000 females we tested, 100% were not vaccinated. And of the obstetricians, we interviewed 91, only 9 were vaccinated. What about healthcare workers? There is a standing recommendation that all healthcare workers must be vaccinated annually against influenza, and facilities that employ healthcare personnel are strongly encouraged to provide the vaccine to their staff. But what is the reality? England, 2014-15, not more than 60% vaccinated in few of the best centers in the world. We also looked at our own place. What is the knowledge, attitude, and practices about seasonal influenza vaccine in Kashmir? We recruited around 1,400 people. Despite the fact that everybody, nearly 84% said that influenza is a potentially severe disease, and they knew that there is a vaccine available against influenza, only 4% had actually received the vaccine. And once we asked them, why did you not participate in the vaccination program? I don't believe flu vaccine is effective. I didn't know about the flu vaccine. There was no time to get vaccine at work. Vaccine might harm my health. Influenza is not a serious disease. And others, I'm not at risk for influenza complication. I'm not in contact with patients. I'm allergic to egg yolk. So they give a variety of reasons for not having themselves vaccinated. And this is an eye-opener. There was a death of an employee in Skims. There was a panic across. Everybody desired and demanded an influenza vaccine. And the hospital administration was forced to give first on payment, then free. And this is the change in the pattern of vaccinations from 2010, the earlier study, to 2013. As you can see, the physicians and physician trainees did have an improvement of vaccination, but how much? Twofold. There was an increase in the nurse and nurse trainers and others by as much as 40 times. So physicians in our study were the most resistant to taking the vaccine. And the question I must try to answer is when to vaccinate where. Influenza circulation has 3 main patterns of circulation. One is called the northern hemispherical pattern, and this is called the southern hemispherical pattern, and then we have the tropical pattern. In the northern hemispherical pattern, which is true of Kashmir as well, we have the peak of activity somewhere in the winters. In the southern hemispherical pattern, we have an exact opposite of it, which is somewhere in the summers of this place and winters of, say, Australia, New Zealand. And then in the tropical regions, areas which are near the tropics, we have a year-round circulation of influenza virus. So that actually dictates your vaccination policies. We looked at 2 cities, both geographically located in the northern hemisphere, geographic northern hemisphere, that is Delhi and Srinagar. Delhi, we looked at, the latitude is slightly less, it's 26, Srinagar is 34. And we found that there was a diagonally opposite pattern of circulation of influenza in Delhi and in Srinagar, despite the fact that both are located geographically in the northern hemisphere. So we said that possibly south of Srinagar, we have something what we have coined as the influenza equator. And this is basically true across China and some areas of Brazil. So influenza equator lies somewhere south of Srinagar at around 30-degree latitude, where areas north of this are exhibiting a northern hemispherical pattern of circulation, whereas areas which are south of this exhibit a southern hemispherical pattern of circulation, which has definite implications for the vaccination policies across the country. And this is how it is that most of the country across has to have vaccination somewhere pre their peak activity, which will be somewhere in summer months, whereas Srinagar should have vaccination at this time of the year. It's except for Chennai and Vellore, where it coincides, the rains are somewhere in October or December, where the peak of activity is that particular time. So what is the vaccination timing for Kashmir? It's now. So I would end by showing these influenza vaccination challenges for universal adoption that came up a couple of months back in the vaccine. In India, the challenges are that there's an inadequate and patchy surveillance. We don't have good surveillance data. There's a disconnect between the perceptions and practices of healthcare workers, especially doctors. They believe something, practice different. There are misperceptions. There are misconceptions about the safety and efficacy of influenza vaccine. Physician societies and bodies do not recommend universal vaccination. Universal vaccinations programs do not recommend influenza vaccination. Cost is a distinct impediment to a large section of the society. 600 rupees may not be a very easy expense for many people. And influenza vaccination has got to be timed differently for different regions of the country. And the biggest impediment ever is an inadequate match. You know that we have to forecast as to which would be the circulating virus. Then you would frame a vaccine for that. And there is a possibility that influenza might give you a slip. It might be a different virus that is circulating and the vaccine might be totally different. There is a non-availability of a universal vaccine that would have been required only once. Newer technologies distinctly have potential advantages, and VLP vaccines, they're a new kid in the block. Preliminary data shows that they're immunogenic, they seem to be safe, but it will be a while before we have the final answer. I must acknowledge the support of the CDC USA, the Indian Council of Medical Research, and my boys in the influenza lab, without whom none of this work was possible. Thank you very much. I'll be happy taking any questions.